I think the first question is, why is the patient being tapered? I like to use, personally, I like the difference between taper to me means like we're coming off the medication completely versus a dose reduction is we're reducing the dose because it's too high, or maybe because of your comorbidities, it's too risky for you to continue on this high dose, or because of the guidelines, you know, your provider wants you to try coming down on the lower dose. So I think the first question is, why is a taper or a dose reduction warranted? Because then that really allows you to set a goal with the patient and a timeline with the patient. Because I've also learned that if they know that information kind of up front, like this is going to be over a few weeks versus a few months, or this you're coming down and off of it no matter what because of aberrant behaviors, versus we're gonna reduce you slowly and there could be pauses along the way. They just like to know that type of information, you know? So I really think the first question is, why are we doing this? And then that's better able for you to set up your plan.
For most patients, we would be doing a slow taper, but you would speed up a taper when there's medically dangerous situations or you're concerned about a patient's safety. Sometimes I've been in a situation where I no longer feel that it's safe to provide the patient with more medications, and perhaps we'll speed up the taper to work within the amount of medications they have remaining.
It could be a use of like a very dangerous illicit substance like cocaine or amphetamines in combination with opioids, whereas marijuana, again, that's very provider specific, but marijuana may not warrant a rapid taper, whereas cocaine or amphetamines might warrant that. Or like she's saying, or like patient who's maybe recently been admitted for an overdose and now comes to your clinic for like a follow-up appointment, you find out this information, and you know they have medication left, so like what do you do at that point? Most likely, like she's saying, reduce them or taper them off with whatever they have left, because that's a very clinically, that's a patient safety concern at that point when they have that history of overdose or recent overdose, or maybe they're suicidal. Any type of those circumstances, I would say.
But yeah, so I'd say for the most part, slow would be for people who've been on it longer, more stable on the medications, and you're not so concerned about risk and their safety, and you would speed that up depending on the risk and safety involved in that situation.
And the rapid taper too could also depend on like your ability to follow up with the patient, you know, like can you follow up with them in a week or a few days, either by telephone or face-to-face, or depending on where they live, or do they need to be admitted to the hospital, and can that all be coordinated and that type of thing. So those are some other things to take into consideration too. So in the context of like an opioid taper and opioid dose reduction, I almost feel like you have to have some sort of bridging therapy in your back pocket. Otherwise, the patient's gonna look at you like you're just gonna reduce my dose and not give me anything else. Like, you gotta have something up your sleeve. So that's where the patient who maybe who was started on opioids many years ago and then has been followed up by primary care and really has not engaged in like complementary alternative medicine or spinal procedures or injections or other non-opioid medications. For those patients, in the process of the opioid dose reduction, that's when I start to introduce these ideas or concepts or refer them to those types of services, especially if they've never experienced them before. The challenge is for those patients who've been on opioids for long periods of time but have already tried a lot of these other modalities or treatments or medications. Oftentimes what I find is now we're going back to try medication you tried 5, 10 years ago that you had some type of side effect on. That's not dangerous to the point where we're concerned of trying it again, but now that you're on a lower dose of opioid medication, I wonder if your response to this medication would be better than it was on the high dose of opioids. And using the pain psychologist is critical and key, I feel like, throughout the opioid dose reduction process, especially, you know, I've had this pain psychologist come back to me and say, we really need to pause this taper. Like, this patient, their function is declining, I'm concerned about them, and that's a very valid reason to pause the taper or maybe potentially keep it there for a period of time. But they're gonna work through with the patient on other healthy coping mechanisms besides just medications. And we're also trying to teach or educate patients that medications are just one treatment option in pain management, and really to get the best results, we need to kind of make your care multimodal.
So I always like to think of pain management as like a pie, and pain medications can be a piece of that pie. And personally, as long as, you know, pounds and calories didn't count, I would definitely want the whole pie and not just a piece of the pie. And so medications are just one piece of the pie, then we need to figure out how to fill in the rest of that pie so that you get your whole pie.
And oftentimes that by offering these other modalities or treatments, the patient's not feeling like you're reducing their dose and not giving them any other alternative. Now I am 100% honest because a lot of them will ask, well, what's going to replace my opioid to the same level? Unfortunately, none of these things work just like your opioid medication does, so none of them are going to be, you know, the cookie cutter replacement for what we're reducing or getting rid of for safety reasons, but these other modalities have evidence to support their use. They may be healthier, they may be better long-term, so at least try them, you know. And if we don't try them, we won't know.